Welcome to this MTech Access webinar. At MTech Access, we provide health economics and outcomes research and market access services from strategy through to implementation. We work with over 80 NHS associates to bring our pharmaceutical and medtech clients authentic insights into the NHS. Our unique NHS relationships guide and validate everything we do in the UK. We can help you answer key questions related to the NHS, from how to communicate with integrated care systems, places and primary care networks, to how to capture pathways of care. Get in touch today to discuss your market access goals. First though, I hope you enjoy the webinar.
Good afternoon and welcome to the MTech Access Words of Wisdom webinar. I'm Tom Clark and I'm back with another of our fantastic guests from the health and care archipelago. Primary care has been in a precarious position for a long time now, and never more so than now. Reducing workforce, concerns about the future of PCNs and an ever-increasing level of demand make it a pivotal time. Lay on top of this the rise in highly infectious diseases and the need to respond to the external structural changes. And it's easy to see why primary care is struggling to juggle its priorities. To help us understand how these priorities are being assessed and managed, I'm joined today by Dr. Alex Deegan, who's the Primary Care Medical Director for the Devon Integrated Care System and Senior GP Partner at the Mid Devon Medical Practice. As well as still seeing patients each week, which you can see Alex is in the practice today. Alex has extensive experience as a commissioner with the NHS Northern, Eastern and Western Devon CCG. And Alex's focuses on influencing and improving healthcare provision for all patients, particularly around transformation, sustainable models of care and the wider determinants of health. Alex, welcome. Thank you for joining me today.
Thanks, Tom. Thanks.
Can you just start by sharing a little bit about your current roles and a bit about the system that you work in?
Yeah, absolutely. So as you said, Tom, I work in Devon. I've been a GP for 17 years now. I'm a GP partner in a rural dispensing practice in the middle of Mid Devon. For those of you that know the area, it's kind of between two market towns called Tiverton and Crediton. So I work in a practice for 3 days a week. And for 2 days a week, I work as the primary care medical director for the ICS in Devon. So the medical director role is a kind of more strategic role, obviously looking at how the NHS kind of fits together and works in Devon, and how we work closely with our partners across the system. That includes our partners in the local authority. Devon's quite a big county. It's obviously in the southwest on the peninsula. We've got Somerset and Dorset to the east and Cornwall to the west. Within Dorset, there are 4 acute providers, so 4 big acute hospitals, kind of at the geographical edges of the county. We've got about 120 GP practices across the whole county. We got a mix of kind of city dwellers and lots of rurality as well, particularly where I am. So my GP practice, I think, is about 400 square miles, and we don't have a single roundabout or traffic light on it.
Fantastic, thank you. And I mean, we can imagine some of the challenges that you might face around Devon. Can you just expand a little bit on some of the sort of specific challenges for primary care in your population?
Yeah, absolutely. So I don't think it's all that different to other parts of the country, really, Tom. But you may have seen in the press last week or the week before, there was some articles on kind of primary care and how well it performs, or how well it's perceived to perform by patients. And Devon actually was the 2nd highest scoring county in the country. So you might think that everything's kind of rosy, but it's not. There are lots of difficulties in primary care, predominantly around kind of demand. That there is more work than it is easy for us to manage. We've got issues with regards to workforce, and again, it's interesting in Devon. Different parts of Devon have slightly different kind of workforce issues. There's always estates issues. And again, that varies across the whole country and across the county in Devon. But predominantly, it's about matching capacity with demand. That's one of the things that I think primary care struggles with most, and again, over the whole country, really.
Yeah, brilliant, thank you. And obviously the context of everything we're talking about is all around the ICS piece, integrated care systems. Can you just talk a little bit about how primary care has responded to some of the challenges in a more integrated way and how it's working across the system?
Yeah, absolutely. I think it's interesting. I think COVID really, in a way, it helped the NHS generally, actually, and the local authorities, because with COVID there was an imperative to collaborate. We had to do things quickly. We had to work with partners who we hadn't necessarily worked with before, and we just needed to make it happen, both for us working in the NHS, but more importantly for the patients. So with regards to kind of primary care and collaboration, there's a lot more collaboration going on. As I said, I've been a GP for 17 years now, and if I turn back the clock and look back to 2005, 2006, each practice was an individual practice, and we kind of kept ourselves to ourselves. We didn't necessarily speak or work with the practice next door to us, and very much looked at what was within kind of our four walls or with our population. So COVID encouraged collaboration, and the other thing that's really encouraged collaboration is the development of primary care networks. Primary care networks, or PCNs, they were set up just before COVID, actually, so kind of 8-9 months before COVID. And so primary care had already started on that journey of collaboration, looking outside our own four walls in our practice. So we were beginning to do that in the year and a bit longer, really, but before COVID hit us. So as I said, I suppose just using my PCN as an example, one thing that made a huge difference to us actually was the COVID vaccination program. Although we were working more closely together, we needed to work jointly to vaccinate all our patients when the COVID vaccines became available at the beginning of 2021. And actually, we vaccinated in a local sports centre. There were 6 practices at the time in our PCN. There are 5 now because 2 of them have merged. But actually, there are all these people in the practices next door that we kind of knew, but didn't necessarily have a relationship with or didn't talk to. And suddenly we had to work together, making sure that we collectively vaccinated all of our patients. And just being put in the same room, working alongside each other, you develop relationships, you're pulling in the same direction. And I'm hoping that kind of stands us in good stead going forward.
Yeah, fantastic, thank you. And a couple of months ago, we saw the publication of the Fuller Stocktake report around sort of primary care and expanding that piece around working within systems. Can you just talk a little bit about kind of the implications of the Fuller Stocktake report in reality for how primary care might work?
Yeah, absolutely. It's a really interesting report from Claire Fuller, and I mean, essentially, my reading of it is that PCNs aren't going anywhere. I think it really puts primary care at the centre of ICSs, and not just primary care, but PCNs as well. I think there's I don't know who coined the phrase, but I often, over years, I've heard the phrase, if primary care fails, the system fails. And I think the Fuller report recognises that. It's really important that we have good foundations in primary care out in the community, because that's where the majority of contacts between the NHS and patients occurs. I think I can't remember exactly offhand, but I think about 90% of contacts in the NHS occur within primary care. We often hear lots about secondary care, but actually they only have about 10% of the contacts.
Yeah, brilliant, thank you. One of the things that is mentioned in that report is this idea of integrated neighbourhood teams as kind of the next step of PCNs or an evolution. What's your kind of understanding of that integrated neighbourhood team, and kind of how might you look at those sorts of ideas locally?
Yeah, so it's essentially what PCNs were set out to do, I think, Tom, and it's just kind of an expansion of the foundations of PCNs. So what neighbourhood teams are is so it's based around a population of a PCN. So PCNs generally around 30 to 50,000 patients. But the idea is all about collaboration. So it's about me as a GP working closely with my district nurses, with other healthcare professionals who are actually employed by other healthcare organisations. So that's the beginning of it, but it actually goes much wider than that. So it's about those community teams, but also about how we interact with secondary care. And actually, some secondary care physicians may end up being part of our community teams. And it goes outside the NHS, so it's much wider than just health. So there are some neighbourhood teams. In fact, there's one up in North Devon where they involve the fire service, the police, the adult social care, other bits of the local authority, and the voluntary and community sector. So it's all about us working jointly together to give the best care we can for our patients, sorry, I keep calling them patients, but for our population. And because there are lots of, thinking of the police and fire service, they come into contact with individuals that have medical issues or other social care issues, and sometimes they end up coming to see us as a GP, but we might not actually be the right person for them to see. So it's just about joining things up, making sure that we improve the health of our population and use the collective resources of all of those sectors that I mentioned. And actually one phrase that I often use, and I'm sure you've heard of it, Tom, is about the wider determinants of health. So I think in the NHS, we're very good at fixing people when they go wrong, but actually there are things like fuel poverty, access to education, access to transport. All of those things have a real impact on people's health, but they're not something that the NHS kind of has responsibility for commissioning or providing. So it's an opportunity for us to work with some of those partners that I just explained to address some of those wider determinants, many of which, if we get right, will stop people from becoming unwell in the first place.
Yeah, brilliant. And probably one maybe misconception of Devon is that actually there's some quite severe pockets of deprivation around the county, aren't there? I think in terms of kind of bringing in the fire service, the police and others, so in these webinars, and I think probably for the audience, just more widely, kind of we all get the idea that bringing everyone together is likely to have benefits. In reality, having those kind of partners part of the conversation around your local population, what do you see as the likely impact of that kind of stuff? Is it that you won't be having people coming in? Is it that they won't be getting as poorly? Is it that they won't be sort of exacerbating when they've got conditions? What do you see as being the biggest impacts?
Yeah, I think all of those, Tom. I mean, hopefully by using our collective resources, we can move things upstream a little bit. Where I've been involved in management and leadership in the NHS for years, and we're often, it feels like we're putting out fires, that something happens and our attention is diverted to sorting out the fire of the day. But what we need to do is to be a bit more strategic, work a bit more upstream, look at those wider determinants of health. That, as I said, hopefully, to be honest, actually a lot of the wider determinants, they start, I said in my job interview for this job, actually, it starts kind of preconception. It's really important that the parents to be are aware of the importance of healthy pregnancy. Then actually when baby's born, actually need to make sure that that the children have the best start, have access to the right nutrition, have access to support through health visitors. So it's all about bringing things upstream, giving people the best start in life, and continuing giving them the best opportunities to live a healthy life, kind of right the way through their life. So it's sorry, just going back to the original question. So yes, it's about prevention. It's about actually when people become unwell, recognizing it quickly, or helping them to recognize it quickly, making sure that they see the right person, they seek help and seek the right person, which might be me in a GP practice, but actually it might be the Citizens Advice Bureau or one of our other partners. And just generally improving the health of the population.
Yeah, okay. And in terms of kind of the clinical aspects of healthcare management that you do in primary care, by having that integrated neighbourhood team and working with those partners, do you see things that you're doing in the practice, whether that may be taking blood or changing dressings or some of those sorts of things that are kind of more community or can be associated with being done in the community? Do you see some of those things might be done by other people elsewhere? So, for example, the fire service might be out and might be able to change a dressing or something with the right training.
Yeah, it might be stretching a little bit to suggest a fire person changing a dressing, but certainly that there are other people that we can use. So I've had conversations in the past about our social care colleagues, for the sake of argument, who are going in and providing personal care to people. Actually, there's no reason really why we couldn't work with them and train them to do some of the basic, maybe not just basic actually, but to do some of the things that historically have been done by other people. And I think historically, again, it's been really difficult because we've been working in silos, and it always seems really difficult to, even when it's the right thing to do, to transfer a budget or transfer money to make it happen. But now we're working as an ICS with a collective responsibility. The hope is that actually some of those conversations will become easier, although it's going to take a bit of time for ICSs to mature, I'm sure. Yeah,
you mentioned the B word there, budgets. Obviously, that's a perennial challenge for everyone within the NHS. So primary care and PCNs have been funded in a fairly consistent way, albeit with tweaks along the way, for some time now. With the introduction of ICBs, do you see real differences in how funding might come down to primary care?
I think that remains to be seen, really, Tom. I mean, as you say, it's kind of worked. It's worked one way for several years now. It essentially, every GP practice has a central contract for the majority of our services with NHS England, and there are a handful of kind of other pots of money that we can access for doing kind of additional services. And then obviously we've got money that comes directly through the primary care network as well. So the money that comes through the primary care network, I think it encourages that. The way it comes down to us, actually, that there are, I was going to use strings attached, that's an unfair phrase, but the way the money comes down, it encourages us, helps us to work together in order to access the money and improve services for our patients. I hope I don't quite know what it's going to look like going forward. At some point, there may need to be a change to the way primary care is funded nationally, and it may be that ICSs, ICBs have more freedom to move pots of money around the system, including to primary care, if that's what it makes sense to do. But I certainly don't think I don't think there's a kind of a plan that's been written down yet nationally, and I suspect NHS England will be having a think about actually whether the present contract is fit for purpose or whether things need to change.
Yeah. Okay. So can I take from that kind of for the foreseeable future, primary care is still going to be driven by that kind of central contracting and local contracting the way that it typically has been?
Yeah, I think so for the moment. I mean, my hunch is that well, PCNs originally were just around for 5 years, and we're three and a bit years into it, aren't we? I can't see PCNs going anywhere, and certainly reading the fuller stock take, it kind of implies that PCNs are here to stay. I just wonder whether actually more of the funding will be done at PCN level, to drive that collaboration, to drive economies of scale, of efficiency. So I suspect that more money will be at PCN base. More future money will be at a larger level of PCN basis rather than individual practice basis.
Yeah, okay, brilliant, thank you. And just, I don't know if you'll be able to answer this or not, but in terms of that bit there about PCNs being here to stay, we hear all the time about PCNs around the country that are kind of sceptical about the direction of travel, or not kind of coalescing themselves because they're waiting for something else to come along. For those kind of PCNs who were not kind of bought into collaborative working, if you could give them a fairly simple message as to kind of why it's important, what would that be?
I suppose that it just appears, Tom, that it's the national direction of travel. And don't get me wrong, at times it's not easy working collaboratively across more than one practice. But actually, there are some PCNs that you see across the country that are really thriving, and there are lots of opportunities. There are opportunities to do different things for your patients, new things for your patients. And I'm someone who very much I kind of embrace change. I quite like change, but I think in every walk of life. Whether we're talking, I don't know, using banking or supermarkets or whatever as an example, things change and things evolve, and primary care, healthcare kind of will evolve. So I suppose I just encourage them to kind of embrace it. It's the only game in town at the moment, and ultimately, although it might be difficult, it's patients that might kind of lose out if PCNs aren't embraced.
Yeah, brilliant. Thanks very much. So shifting attention now to kind of priorities within primary care, just for our audience's benefit, could you just kind of list, from your perspective in your role as the medical director, what are the top kind of 2 or 3 priorities for you at the moment around Devon?
I think, and I said at the outset, actually, Tom, kind of demand and capacity. So how do we match them? There's more work than primary care can deal with, really. So how do we help that? Stability of practices, kind of going forward. And again, it's not unique to Devon, but across the whole of the country, there are practices that are struggling to recruit, or whether that be GPs, nurses, reception staff. Interesting. One of my observations actually is that we hear in the news about difficulties getting HGV drivers and people working in supermarkets and hospitality and everything. But actually, it's true in primary care as well. It can be really difficult to recruit not clinical staff, but kind of administrators, receptionists. So making sure that practices can thrive, making sure that they are stable, that's really important at the moment. And the other thing is actually how are we going to cope through winter? I'm really worried about this winter, for a number of reasons. But actually, how can we set up primary care and how can we support primary care and the wider system to make sure that when we go through our busy winter period, which I suspect could well be is likely to be our busiest, most difficult winter ever. How can we support them and make sure that patients get the services that they need?
Yeah, and you mentioned winter there, and obviously there's been all sorts of things in the news about how difficult summer is at the moment, let alone winter, and we're aware of the likelihood of more COVID waves and quite an impactful flu season. Can you just talk a little bit more about kind of what you are worried about for the winter that we're heading towards?
Yeah, it's about demand and capacity again, isn't it, Tom? And about prioritising kind of what we do. Actually, everyone says the whole year is like winter now, and there's an element of truth in that. But all your respiratory illnesses and kind of frailty and things, that's much worse kind of over the winter period. And I mean, in my experience over the last 17 years, it kind of, accepting I'm quite far south, it might be different a bit further up north, but we kind of start getting busier beginning of October, middle of October. Depends a little bit on the weather. Actually, if we have a kind of warmer October, it starts a bit later, and then we're really busy right through till kind of end of February, and then often it kind of tails off then. So actually, how do we make sure that we've got the right capacity and flex within primary care, so that when people need a primary care service, they got access to it? How can we actually, quite often I'll see patients who I might not be the right person or might not necessarily be the right person for them to see or to help them. So actually, how do we make sure that not only do they have access to us in primary care, but how do we access or can they access self-care through the local pharmacy? How can we get information to them in other ways to access self-care? And sorry, I got a bit distracted there. Someone sent an email to me. I don't know whether you heard the bing.
Yeah, I should have sent them you're out of office for you.
Sorry, Tom, just repeat that question again for me.
It was just really about kind of expanding on winter and what's going to be particularly worrisome about the winter that we're heading into.
Yeah, and then lots of our GP practices have got gaps in the workforce. So actually, if there are gaps in the workforce already, and primary care is generally under strain, if you add more patients into that, actually it doesn't take much to make it more likely to fall over. And I'm really, and again, you see it in the national press, don't you? And I'm not singling out healthcare as being the most affected by COVID, because again, it's affected all sectors. But really worried about staff in the NHS and in primary care, because it's been a tough 2-3 years, and we're, as I said, that there's not so much of a lull in the summer. It just seems to be continual. We know there are lots of people retiring a bit earlier. There are people taking time off sick because of the stresses. So sometimes it feels like a bit of a deck of cards, really. So yeah, how do we make sure that we support primary care, make sure they've got access to the right workforce, make sure that the patients got access to the services that they need over the busy winter period.
Yeah, and I mean, in terms of that's lots of wicked problems there, aren't there, about workforce and those sorts of things. I think sometimes we pick up a bit of a sense of kind of defeatism around these are just problems that are there and we can't do anything about them. What are you doing, or can you do to kind of mitigate some of those challenges around the things that you talked about?
Yeah, I mean, there are a number of things. I suppose it depends what you're looking at, isn't it? There's certainly the there are some digital, and not solutions. Solutions would be the wrong phrase, I think, but there are some things that we can do digitally to help. So we can, that actually every GP practice in the country now does kind of some kind of electronic consulting, which isn't everyone's cup of tea. I'd say I quite like it, actually. I often find it a more efficient use of my time. I can tend to get through them more quickly, and patients get the right care. We can actually, one of the things that's been done nationally, which I've been involved in Devon, which has been quite helpful, is setting up things like mentoring schemes. So it's the NHSE mentoring program, which we put in place in Devon. And the idea of that is twofold, actually. So that most of the mentors, or a number of the mentors at kind of middle or end of their career, gives them something slightly different to do, helps retain them, but also allows them to kind of transfer some of their knowledge, skills and wisdom to some of those newer GPs that are just starting out in the first kind of year or two of their career. There are often pots of money that we can give to primary care to enhance capacity over the winter period. So there was a winter access fund last year that practices could get money to put on extra GP clinics or paramedic clinics. There were a number of ways that you could spend it. So there's all sorts of things. It's a bit like marginal gains, isn't it? So there's not one solution, but there are lots of little kind of things that can be done that hopefully add up to something big. But it'll still feel really busy, and it'll still be a really difficult winter, no matter how much we do, because there's always a concern that if you increase capacity, it'll get filled. So we could double or triple the number of primary care appointments over winter, but they may well all get filled.
Yeah. Okay. So in terms of the demand piece, then our audience will often largely sort of be interested in particular patient groups. Is there stuff that you're looking at the moment about particular population groups, I should call them, or particular pathways of care? So are you looking, for example, at elements of respiratory care, and how best are we managing either the pathway or that respiratory population to help kind of lower that demand and improve their quality of life as well?
Yeah, I mean, respiratory, over winter, respiratory and frailty are always the two biggies, aren't they? And I think generally primary care is quite good or relatively good at respiratory, making sure that our patients have access to standby courses of steroids and antibiotics for their exacerbations of COPD and asthma. And frailty, again, it's always kind of top of the agenda, isn't it? I'm not sure that we're doing, or in just thinking in Devon, I'm not really involved in anything particular with regards to frailty. And I know that some people kind of feel that we've concentrated too much on frailty over the years and should be looking at other things now. I mean, one of the things that I'm quite excited about, not necessarily for this winter, but kind of going forward, and this is with my strategic hat on, it is the use of data and population health management to help our population. So for those attendees that aren't aware of population health management, essentially the idea is that we get data from all parts of an ICS. So that would be primary care, secondary care, community services, mental health, the local authority, and actually we use that data and crunch it to look at gaps in services, gaps in pathways, particular population groups that might be pitching up in as emergency admissions regularly, and actually targeting interventions to try and reduce that. It's one of the things I'm really keen to do in Devon, because our urgent care system is struggling, as is everyone else's, to be fair. But actually, can we use that data to develop interventions or new services that reduce deterioration, reduce demand, help us identify kind of iller people more quickly so they don't get so ill, and reduce kind of length of stays and things like that.
So in terms of that kind of population health management piece, obviously that's stuff that you're looking at or starting to look at within the system. Would you be receptive to people coming in, sort of third parties from industry or wherever it might be, to help flag those gaps for you? So you talk about urgent care, so whether it's stroke, heart attack, some of those, big ticket items, I suppose. If people were coming along with that population health data and suggestions or ideas or best practice from elsewhere, is that something that at this moment in time would be something that is of importance to you?
Yeah, I mean, I'm always happy to get help from anyone that will offer it to me, Tom. So yeah, always happy to hear about ideas and have conversations that might help my population. Population health management is a relatively new thing. NHS England have had two kind of pilots so far, a wave 1 and a wave 2. So I think they've had about 5 or 10 areas across the country where they've kind of just started doing a bit of population health management to build up the skills, make sure we know what we're doing. But actually now population health management is going to be a priority for all ICSs and for PCNs. There are some things written into the PCN contract with NHS England that really encourage us to get involved with PHM. And actually, to be honest, I don't need that encouragement because it's the right thing to do. It's just until now, and again, it's partly because we've kind of worked in silos and lots of different organisations. It's been really difficult or impossible to get all the aggregated data together. But now it's getting easier to do that, particularly as we're working in ICSs.
Yeah. So you talk there about the different priorities, and some of them are contractual, some of them are data-driven, if I want a better phrase. When it comes to that actual kind of decision-making process about what are we going to focus on this week, next week, this year, next year, who is involved in that process? What drives it? How do you, as a practice, as a PCN, as an ICS, land on the things that primary care is going to focus on?
Yeah, I mean, there's lots of business as usual, Tom, which sometimes, in a way, some of us might have taken our eye off the ball a little bit over the last 2-3 years during COVID. So one of the things that a lot of practices will be doing is looking at, I should better explain it for the attendees who might not know about it, but there's something called QOF, which is a quality and outcomes framework, where actually every GP practice has to, or is asked to make sure that we are reviewing our patients with diabetes, heart disease, COPD, asthma, ischemic heart disease, make sure they're on the right medication, make sure their blood pressure or their conditions are well controlled. During COVID, QOF was suspended a little bit, and we were asked to concentrate on other things, including COVID vaccinations. So we need to make sure that we're on the ball again this financial year. QOF years run from April to March every year. There's a backlog probably a backlog of work there, because some of those reviews didn't happen. So we need to make sure that we get back on board with the business as usual. And then also, to be honest, a lot of the kind of strategic work and priorities is partly driven by the PCN DES. So it's looking at kind of widening the number and types of staff that we have in practices. So our paramedics, our social prescribers, mental health professionals. So a lot of it is, I was going to say, I'm not sure that it's driven or influenced really by the PCN contract with NHS England. And then depending on, and using any PCN as an example, the people that lead the PCN they'll be getting involved with population health management. They'll be trying to understand their population, their practices, where the practices feel the pinch points are, what services we need to look at in investing in. And I mean, sometimes, I suppose historically, it's kind of been a little bit of a hunch or I fancy this or that member of staff to help with this. And I think there still will be an element of that. So sometimes it is just a hunch, but as time goes on, hopefully it will be a bit more evidence-based and backed up by some of that data from the population health management work.
Yeah, absolutely. I suppose that there is a little bit of a tension there, isn't there? If you're looking at your population health data, which says something about your local population, on the other hand, you've got QOF, PCN, DES, which are the same wherever you are in the country. You're being measured on the same things in the same way, which may or may not resonate for you. Do you see a tension there? And then I suppose the follow-on to that is if you're restricted in your capacity and the data is telling you focus on this particular population, QOF is saying no, actually focus on the other. How would you resolve that? Or is it about how do you find the kind of the middle of that Venn diagram to try and satisfy everything?
Yeah, it's really difficult, Tom, and I mean just another complexity to add to it. So in a PCN, it may be that we look at the data, and in my PCN there are the 5 practices, and it may be that there's a gap in service or a particular need, but just for the patients in one of those 5 practices, and not for the other 4. And I suppose I very much I think it's different for different people actually. Some people, even though we're in a PCN, still see their practices population as the kind of most important thing. My practice population is important, but I kind of feel an ownership to the whole population of the PCN, so the other kind of 30-odd thousand as well. So it's about negotiating, it's about prioritizing, and I think, as you're just alluding to, Tom, there's only so many people in a PCN. There's only so many hours in a day for people to work, and we can't do everything. But I think as long as we're making steps in the right direction, I was going to say baby steps. I'd like to take big steps, but I think we just have to accept that we can't sort all the problems kind of in year one. It's a much longer term thing, and as long as we're making steps towards that, then that's great for the population.
Yeah, okay. So in that kind of pragmatic example, I suppose, so you've got 5 practices, one of them wasn't doing so well in whatever it might be, dermatology referrals or outcomes or something. I'm kind of taking that, rather than saying, okay, well, how do we train them up in dermatology and improve the quality of their referrals? It might be a case of, well, let's get the other 4 practices doing that work for them or picking that up, or providing some sort of support or supervision there, rather than focusing on that. So it really is that kind of collaborative approach. Would that be right?
Yeah, absolutely. So I'm just trying to think of actually, I'll use an example, Tom. So one of the GPs in my practice does, he's skilled at and enjoys doing minor surgery. So chopping out ingrown toenails and bits and pieces. Which is kind of an extra service that not all practices do. There is some funding for it if you want to do it, but it may be that we see in one of the neighbouring practices that they can't offer it, but there's a demand by their patients, and it may be that my partner can do some of their minor surgery. So as you say, I don't think there's one answer. It might be sharing staff, it might be sending in expertise from another practice. It's about finding the right solution for the right problem, but very much in a more collaborative way than the NHS has been set up in the past.
Yeah, okay. So anyone coming to you to talk about doing things differently or how a particular kind of clinical area was doing is much better talking about the PCN as a whole rather than your practice, because you might almost deliberately have gaps, or you might be very aware of your gaps, but other people are looking after those for you.
Yeah.
Yeah, okay. Fantastic. We talked a bit about some of the other agencies involved in kind of the ICS, the Integrated Neighbourhood Teams. In terms of that provision of care, there's other sort of agencies like the Rapid Diagnostic Centres, obviously all sorts of things around the voluntary sector. How involved are they at the moment in the delivery of care and kind of managing some of your demand?
Sorry, what was the second one, Tom? The Rapid Diagnostics?
It was the voluntary sector and kind of some of the resources they've got, I suppose, social prescribing and everything that might link to.
Yeah, so I think most, speaking from a Devon point of view, I think I'd be surprised if not all of the PCNs have kind of social prescribers attached to them now. Certainly in my PCN, we've got access to two social prescribers. I find them a godsend. They're really, really useful. In fact, I had a conversation with a patient this morning who was in contact with one of our social prescribers last year for a few months and found it really helpful, and essentially wanted a referral back to them for help for another problem. So I think for the right patients, they're really helpful, and I haven't measured it, but anecdotally, they take work off me in the GP practice, and provide they can spend much more time with patients than I can. I think generally across the country, the voluntary sector or third sector is getting much more involved with PCNs and with patients, but I think it's probably very variable. So all PCNs are of different maturities. Again, there's so many things that influence how well a PCN works. It's the population, it's the practice. It's about, actually, as in any walk of life, often it can be because of personalities, that there's so many things that influence that maturity. And some of them are less mature, but then there are others, as I mentioned earlier, that are really thriving and flying, working together kind of with neighbourhood teams, including the voluntary and community sector. And I know I was hearing a GP from Oakhampton speak a couple of weeks ago, and I was just so impressed with, she works in Oakhampton, but her PCN is kind of north bit of Dartmoor, and she spoke so passionately about the neighbourhood team, the links with the mental health services, the links with the voluntary and community, the voluntary sector. And it's clear that population, that PCN is thriving. The population is getting access to newer services and newer ways of doing things. So that there's a PCN like that, but then there'll be others that are much further behind. And I'd probably describe my PCN as being somewhere in the middle.
Yeah. Okay. Just thinking now about sort of specific bits around patient health or population health. Obviously, there's lots of different competing health risks at the moment. We talked a bit about COVID, a bit about flu. Before we came on air, we were talking about monkeypox. So all these different things that are converging, as well as the backlog that we're hearing about, and then there's been more in the news over the last day or so about excess deaths and those sorts of things. Where do you see as being the biggest areas of health being negatively impacted?
So when you say areas, you're thinking
so in terms of clinical areas or therapeutic areas.
I think it's difficult to pick out one thing, Tom. I mean, and again, probably most of the attendees would have seen in the media about the backlogs in care across the NHS. The waits are really long, no matter what speciality you're talking about. It does vary across the country, I suspect, because sometimes there will be an acute trust that has a speciality that's understaffed or under particular pressure. But it's kind of yeah. I don't think I could pick out one thing really. I mean the specialities that generally have the largest numbers of referrals are things like orthopedics, often for kind of hips and knees, and things like dermatology. My experience is that the waits in dermatology are okay. Actually, some of the waits for orthopedics are long, much longer than we'd like them ideally. But yeah, I think all specialities are affected. Have lots of conversations with patients who, in fact, again, I had a conversation with a patient this morning who said, "Oh, I was meant to be followed up 6 months after my last appointment, and it's now 2.5 years later. I phoned the secretary, and the secretary said, 'Don't worry, you're on the list. You'll be seen, but we're just not quite sure when.'" Yeah, every speciality is affected. I suppose one of the things one of the things I worry about most, thinking about it, is kind of mental health. Mental health that has arguably been underinvested in for a long time, and with the effects of the pandemic, with things like long COVID, we've all seen in recent weeks kind of the effects of inflation and cost of fuel. It's like a perfect storm, isn't it? And lots of people have been struggling because of COVID, and actually later on in the year, if they're going to have to choose between kind of heating and eating, and the stresses of kind of looking after their finances, I do worry about the kind of population's mental health going forward.
Yeah, and you talked there about worrying about mental health. We did two different hats. So one as a GP, one as an ICS medical director. Do you have the same worries with both hats on, or are you more worried as a GP about one thing than you might be as a kind of a system leader?
I suppose. Oh, is it different? As a system leader, I worry. Yeah, mental health worries me, and kind of the effects of kind of late presentations and kind of backlog of work that and urgent care, bit of everything. I suppose what worries me most in my day job, some of the kind of churn in the system worries me, or maybe frustrates me is more of a fair phrase to use, because sometimes and again, part of it is driven by that backlog and those long waits, and people not quite being sure when they're going to be seen or what's happening next. They'll often come to me to kind of chase their referral or find out where their scan result is. And actually, and I'm not blaming secondary care for this, because actually everyone's under pressure. But when that happens, it takes up an appointment in primary care for someone that could have had it with a I was going to say with a true health need. I'm not saying the other person didn't, but with a kind of an on the day kind of health issue that needs sorting. So that's kind of what frustrates me, I think, on a day-to-day basis in my day job in the practice.
Yeah, brilliant, thank you. We're coming towards a close, but we've still got a couple more questions to go with. Over the next 6 months or so, if you had the resource and capability at your disposal to do, what would you do differently to go? Well, I suppose thinking with both hats on, whether there's a difference between practice level and ICS level, but yeah, what would you change if you could do?
I think I would. I've already alluded to it a couple of times, actually, Tom. But I want to move away from just fighting fires. I want to look forward and be a bit more strategic. So I want that the fires are there and they need putting out, but we need a bit of dedicated time to plan for the future, because otherwise we're just going to go round a continual circle of fighting crises, fighting fires, rather than thinking about, actually, regardless of those fires, which will happen anyway, what does our population need in 5-10 years time? How do our services need to develop? How do the different bits of the ICS work together? So I think if I could ask for one thing, it'd be a bit of headspace and time to do that strategic bit of work, because it's as important as the day-to-day what's going on today. And actually I think that's true in both of my roles. So both in my ICS medical director role, and also in my kind of partner role in my GP practice. So having a bit of time to be strategic, work out where we need to be in a few years' time, and work on a plan to get there.
Yeah, and what do you think your sort of your nursing or your GP colleagues in primary care would say?
I think I think probably a lot of them. I think workforce and stability of their practices. I know a lot of GPs. The majority of partners in practices are GPs. There are others, lots of practice managers and nurses are partners as well, but the partners are predominantly GPs. So that they're worried about staffing, both from a GP point of view and from actually generally clinical point of view. I know I said earlier that some of the reception staff, etc., can be tricky to recruit, but actually they're worried about the workload, and in the context of the dwindling workforce. I mean, one thing I don't think I've said yet, Tom, is that there are, for a number of reasons, for lots of people taking kind of earlier retirement than they would have done, and actually it'll make things worse. And again, I mentioned earlier about kind of well-being of the staff in the NHS as well, but I worry that or just want to improve things so we don't end up in the vicious circle of people suffering at work because of the huge workload, then it taking a toll on them as individuals, then taking time off work because of stress, or deciding to leave the professions. Somehow we've got to break that cycle, and I think that's what my GP colleagues, particularly the partners, would be keen to see.
Yeah, fantastic. And just one final question for today. I mean, for our audience, particularly those working in industry, if you had one bit of advice for them in engaging with primary care at the moment, what would that be?
I think I think I might give two bits of advice, actually, Tom. So I think there's something around that kind of population health work piece that people will be getting on with, and also anything that can be done to help with workforce and efficiencies. Again, just going back to what I was saying 30 seconds ago, it's the workload and the workforce that is kind of keeping GPs awake at night. So anything that can be done to help with that, I think often you'll find doors open.
Yeah, Brilliant. Thank you very much, Alex. We've hit 3 o'clock, so that's time for today. So thank you very much for joining me. Great insight there from you. So thank you very much indeed. To the audience, we are taking a break in September. We've got our symposium at the end of the month. In place of this, we've got a few tickets left for that. If you go onto our website, you might be lucky enough to get one of the last ones. Yeah, we'll be back in October with our next instalment of the webinars. So thank you very much for now, and look after yourselves, and we'll see you soon.
Thank you for watching. If you'd like to find out more about our work with the NHS or how we could support your market access goals, please email info@mtechaccess.co.uk or visit our website at mtechaccess.co.uk.